Osteoarthritis, pathophysiology, and treatment. After the completion of this presentation, the viewer should be able to describe the cause, frequency, and implications of osteoarthritis, outline the non-pharmacological methods used to treat osteoarthritis, and compare and contrast the most common medications used to treat osteoarthritis, including mechanisms of action and potential side effects. Arthritis is Latin for inflamed joint, and collectively, in other words, all the different types of arthritis, are a major cause of disability for adults and even young children, depending on the type of arthritis. Approximately 22% of American adults have some kind of doctor-diagnosed arthritis, and the prevalence increases to 50% for adults that are 65 years old and older. There are at least 100 types of arthritis, but the most common type is osteoarthritis, sometimes referred to as the wear and tear type or the degenerative type of arthritis. Osteoarthritis, often abbreviated simply as OA, is a degenerative disease that slowly destroys the cartilage, the connective tissues, such as ligaments and tendons, and the bone within joints, in particular the ball and socket joints, such as the shoulder, the knee, and synovial joints in general, which are prevalent in the spine. OA occurs primarily in the hands, the hips, knees, and spine, in other words, the weight-bearing joints, and also to a lesser extent in the feet, in particular the big toe. Approximately 27 million Americans have some form of OA, and it's mostly in middle-aged and elderly adults, which makes sense because OA is essentially a wear and tear type of process. OA is a top cause of disability in elderly Americans and other people around the world. But despite its high frequency in the population, the cause is not completely understood, although overuse is certainly a contributing factor. As well, there's no officially recognized cure for OA, but clearly there's different medications to deal with the pain and the inflammation, and there are many natural protocols that can slow down, halt, possibly reverse OA, and we'll get into that a little later. The diagram to the right, you can see the most common areas of the body that OA affects, such as the spine, in particular the lower spine, the lumbar region, but also the neck or the cervical region is common as well. The hip, in particular the glenohumeral joint, large ball and socket joint. The hand, of course, the foot, in particular the big toe, as mentioned, and also the knee, which is technically not it's a synovial joint, but it's not a ball and socket joint, it's more of a hinge joint. OA mainly affects the commonly used and weight-bearing joints, such as the hip, low back, knee, as noted previously. The process of osteoarthritis begins with erosion of the joint cartilage, which is typically preceded by drying out of the cartilage. And this leads to fissuring and cracking within the joint cartilage. And the loss of cartilage over time leads to bone contact, bone on bone, which of course triggers bone destruction and remodeling, inflammation, pain, and reduced range of motion at those joints. Progressive OA can end in joint fusion, which is the body's strategy, if you will, of dealing with the problem and trying to stabilize the joint. Joint fusion, ironically, typically causes less inflammation and pain, although range of motion is almost completely reduced. OA is much different than rheumatoid arthritis or gout, but it can occur at the same time, concurrently with those other types of arthritis. In the diagram to the right, we have an anterior view of the right knee joint, and you can see some of the processes that are common with OA. For example, we have the eroding meniscus, which is another term for the cartilage within the knee. That is the type of cartilage that is between the bony cartilage. Typically, meniscus are disc-shaped. We also have erosion of the cartilage that is attached to the bone itself, exposing the bone and causing bone-on-bone contact. And then we can see on the lateral side bone spurs, which is an attempt to remodel the joint, cause stability, and of course those bone spurs can cause further inflammation and pain if they cause injury to surrounding soft tissue, such as ligaments and tendons. Osteoarthritis involves reduced proteoglycan and synovial fluid production within synovial joints. Most synovial joints are the ball and socket type, but not all. For example, the knee is a hinge joint. This lack of synovial fluid production leads to dry cartilage, less lubrication within the joint, and therefore more friction or grinding. I'll introduce a couple of terms here that we'll talk about in more detail later in the presentation. One is chondroitin sulfate, and that's a type of glucosaminoglycan or a GAG chain that's needed to make proteoglycans. Hyaluronic acid and glucosamine are other components within the synovial fluid. We'll talk more about those when it comes to the natural supplements that can help with OA. With the progression of OA, the cartilage thins and disintegrates. Often it breaks up and releases pieces into the synovial space, and larger chunks are often called joint mice because they can move around and get lodged in inconvenient places. This cartilaginous debris frequently causes inflammation, instability, and pain. Depending on where these chunks or joint mice get lodged, typically it causes sudden locking of joints in the knee or the shoulder. The bone-on-bone contact can cause more inflammation, pain, and reduced range of motion. And as mentioned, the bone spurs, also called osteophytes, form in an attempt to stabilize the joint and ultimately fuse it together. These bone spurs aren't really caused by consuming too much calcium, as some people might think, although the process can be accelerated by having too much calcium in the blood. And that's not usually due to eating calcium-rich foods or taking too many calcium pills. That's usually because of the body, or the blood, is too acidic, and the body is removing calcium and other minerals from the bones, dumping it into the blood in attempts to make it more alkaline, because the blood must be maintained at a pH of around 7.3, 7.35. That's the main process involved with osteoporosis. So people with osteoporosis, generally speaking, have a lot more bone spurs, and osteoarthritis is linked to that condition as well. As noted, bone spurs can injure connective tissues that surround these joints, but also nerves and small blood vessels. Mild to moderate joint pain and stiffness, especially in the morning or after inactivity. The pain can be sharp if it's coming from the joint itself, or achy if it's coming more from the muscles, and or burning if the nerves are involved around joints that are affected with OA. Sometimes all three types of pain are involved. Bunion or node formation in peripheral joints is common with OA, especially in the hands, around the knuckles, or the feet, in particular the big toe. Reduced range of motion and general loss of function are common with OA, as is mild to moderate swelling and joint enlargement. But the swelling or inflammation is not severe with OA, and that's a distinguishing characteristic from rheumatoid arthritis or gout. In fact, RA is typically called the inflammatory arthritis because of its severe inflammation, whereas OA is typically referred to as the degenerative arthritis. So inflammation is present, but just not to an extreme extent. OA of joints typically causes cracking or grinding noises with movement, often called crepitus. OA is also associated with muscle weakness, atrophy, muscle spasms, and or muscle pain that is typically of the achy variety, as noted. The symptoms of OA usually get worse with cold, humidity, or inactivity, and they're typically worse upon waking in the morning. Symptoms of OA usually improve with mild exercise, which distinguishes it from RA, although moderate to severe exercise, especially the pounding type like jogging, can actually make OA worse. And that's why non-weight-bearing activity, such as swimming, is typically recommended for patients that are suffering from OA. One of the main risk factors is age, because the incidence of OA increases quite dramatically with age, due primarily to additional wear and tear. Just because OA is much more common in the elderly does not mean that it's a normal corollary of aging, because it's not. Believe it or not, there are 90-year-olds out there that have no OA symptoms and no evidence of any sort of joint destruction on X-ray. So just because a person uses their joints for many years, if they are used in normal fashion and they're in otherwise good health, for example, not overly acidic, and they're not malnourished and suffering from any nutritional deficiencies, joints should function normally for many decades. Obesity is another major risk factor, primarily because it increases the load on weight-bearing joints, such as the ankles, knees, hips, and lumbar spine. Some research indicates that the adipose tissue may produce certain chemicals that promote joint inflammation and damage. Poor posture is also another risk factor for OA. Slouching, of course, puts excessive strain in the thoracic spine, causing a humping with time or a hyperkyphosis. Leg crossing causes excessive strain and sprain on the knee joints and the hips. Stomach sleeping often puts much more pressure on the lumbar spine, the shoulder joints, and also the neck. Injuries are a common risk factor or outright cause for OA. Musculoskeletal injuries, especially those derived from car accidents or motor vehicle accidents, can weaken muscles and connective tissue, damage the cartilage within the joints, and in general lead to biomechanical imbalance within the skeleton. Injuries from overuse are big risk factors too. For example, baseball catchers are more predisposed to OA of the knee and the hands. But certain desk jobs that may involve excessive sitting also lead to chronic low back and hip problems that can put you at higher risk for developing OA. Genetics are linked somewhat to OA, especially OA of the hands, and also inherited bone abnormalities such as bow legs or a naturally short leg can affect the biomechanics and joint stability and function and increase the risk for OA also. As noted previously, the actual mechanisms for OA are not necessarily perfectly understood, and of course, modern medicine does not recognize any cures for it. In some cases, it's obvious what caused OA. For example, if a person is in a severe motor vehicle accident and suffers severe whiplash of the neck, and then later, perhaps a few years later, develops OA of the cervical spine, well, then the cause is fairly obvious. But in most cases, it's not so obvious according to mainstream medicine. However, there are a number of alternative theories that may account for the frequency and the increase of OA that we see in modern times. And one of them is chronic vitamin C deficiency. Recommendations for people range from about 75 milligrams to 125 milligrams daily, depending on gender or pregnancy or whether or not you smoke. And many scientists, including the late Linus Pauling, thought that was ridiculously low for a human being and not nearly enough, because studies on primates indicate that a medium-sized primate, in particular in captivity, needs at least 3 grams a day, or 3,000 milligrams, to live healthily and survive in a zoo setting. And of course, vitamin C is needed to make collagen, the elastic-like compound in all connective tissue. In fact, it comprises about 50% of cartilage. Therefore, vitamin C is needed to repair cartilage in all connective tissues. And perhaps we are not getting enough. Another alternative theory involves a lack of essential amino acids, in particular methionine and cysteine, which are 2 sulfur-bearing essential amino acids needed to make proteoglycans and repair tissues. Therefore, it's possible that vegetarians are at higher risk of OA because most plant-based foods do not contain all of the essential amino acids. Some do. Soybean and hemp seed, for example, do. But of course, all animal-based products, whether it be meat, dairy products, etc., are complete proteins because they contain all essential amino acids. Another alternative theory is the cooked food syndrome. The vast majority of modern people no longer eat raw food. They cook all their food. And high heat destroys a number of nutrients, in particular vitamin C, and it also reduces the bioavailability of amino acids. A number of studies show that test animals develop OA simply by feeding them cooked foods. Another theory is the skewed or out of whack fatty acid ratios. For most Americans, the omega-6 fatty acid to omega-3 fatty acids are at a ratio of at least 20 to 1. But a more ideal ratio should approach 1 to 1, or at the most 3 to 1 in favor of the omega-6s. The reasoning is because omega-6 fatty acids in abundance promotes inflammation, whereas balancing them off with omega-3s reduces inflammation. Another theory is overuse of medications, especially non-steroidal anti-inflammatories. All medications promote over-acidity in the body, which therefore promotes the processes of OA and also osteoporosis. But NSAIDs in particular, especially longer-term use, are linked to actual joint destruction, which is ironic because most people take NSAIDs due to joint symptoms such as pain and inflammation. And another alternative theory involves a chronic low-grade dehydration. Interestingly, the thirst mechanism doesn't kick in until most people are about 10% dehydrated. So it's possible for a person to be 8 or 9% dehydrated at all times and not really feel too thirsty. Of course, not drinking enough fluids can cause dehydration, but often it's not drinking the right kind of fluids. In other words, people drink most of their fluids with caffeine-based compounds. And I'm talking about coffee, black tea, soda pop. And as we all know, caffeine is a strong diuretic. To start with, a medical history is important to establish possible genetic links within the family. History of serious trauma, such as motor vehicle accidents, and potential repetitive use issues, depending on what the person does for a living. Physical exam is important in order to check for various symptoms, such as joint tenderness, pain, enlargement, or reduced range of motion. Imaging, of course, is an excellent diagnostic tool. Its cartilage thinning and joint debris, bone spurs can all be visualized on MRI, CT, and X-ray. Of course, on X-ray, cartilage cannot be seen, but it can reveal narrowing of joint spaces, which infers cartilage destruction. Joint aspiration and blood test can be done to rule out rheumatoid arthritis and gout. With RA, the technicians are looking for rheumatoid factor and elevated erythrocyte sedimentation rates. And with gout, you're looking for high uric acid levels. OA does not affect other organs like rheumatoid arthritis does. In fact, RA is classified as an autoimmune disorder that can affect various parts of the body. And another distinguishing element of OA is that it doesn't cause skin rash or psoriasis like psoriatic arthritis does. So if a person has achy and painful joints and skin rash like psoriasis, typically it's psoriatic arthritis and not OA. The image to the upper right is an anterior view of the left knee, and you can see reduced joint space, in particular on the medial side there, on the inside part of the knee. Quite a significant reduction, which infers cartilage destruction. And of course there's a fairly sharp looking osteophyte or bone spur in response. You can see sclerosis of the bone on that medial portion of the tibia, and that occurs in response to the bone injury and inflammation. It's a greater deposit of minerals in an attempt to strengthen that injured bone. On the lower left image, we have a lateral view of the lumbar spine, and you can see reduced joint space, especially between lumbars number 3 and 4 and 4 and 5. You'll also see various joint spurs, sclerosis or whitening of the bone in response to the injury, and also lateral stenosis, which is a narrowing of the space behind the vertebral bodies where the spinal nerves come out to innervate various muscles and joint and organs. As previously noted, incident rates of OA increase with age, but they level off around the age of 80. Perhaps surprisingly, women have higher rates of OA than men, especially those beyond the age of 50, and particularly OA of the knee. More specifically, men have 45% lower risk of knee OA and a 36% reduced risk of hip OA compared to women. And why this is? Well, it could be because obesity is a little more common in women, perhaps greater inactivity levels, perhaps hormonal changes, perhaps women have higher rates of vitamin C deficiency, perhaps they're a little more dehydrated on average. It's hard to say, but it certainly deserves some more research. In fact, in regards to women, their incidence of positive radiograph findings on X-ray for the knee increases 2% per year. Osteoarthritis affects about 14% of all adults beyond the age of 25. However, that number jumps up to 34% if you look at just those people that are aged 65 and older, which represents about 12.5 million Americans. Now, overall, about 27 million Americans suffer from OA, although those are 2005 stats. And that's up from about 21 million that was approximated in 1990. Prevalence of OA, at least in terms of radiographic evidence, and this is moderate to severe changes that are seen on X-ray, OA of the hand is most common. Of course, the prevalence is greater in females compared to males. And you can see next comes the feet, the hip, and then the knee is least common in terms of radiographic findings. But if you compare that to symptoms of OA, in other words, pain and some inflammation, you'll see that knee is most common at 16%. Essentially, what this is saying is that the pain and the inflammation and the symptoms is usually the first to occur, and that seems to be felt mostly in the knee. And then later, we have the joint destruction that is visualized on x-rays, but it takes some time to develop. Osteoarthritis can impact people negatively in a variety of ways. The job-related costs associated with OA are estimated to be as high as $13.2 billion per year in the United States. So there's a $7.9 billion estimated cost of knee and hip replacements, at least in 1997, and it's likely double that amount now. The total annual disease cost of OA is approximately $5,700 per person. And by disease cost, that's typically the cost of medications or rehabilitation or supplies like canes or walkers, things of that nature. OA of the knee is the leading cause of disability among non-institutionalized adults in the United States. About 80% of patients with OA have reduced range of motion, and 25% cannot perform some activities necessary for daily living. And 11% of those actually need help on a fairly regular basis with home care. One common sense and effective approach to OA is lifestyle changes. For example, weight loss, especially via regular exercise, and this is typically non-weight-bearing types such as swimming, helps prevent OA and reduce symptoms. For example, every 10 pounds of weight loss over 10 years reduces the risk of developing knee OA by 50%. Regular non-weight-bearing exercise also improves muscle strength, decreases joint pain and stiffness, and it can lower the risk of disability. There are a number of physical treatments that can help with OA, including chiropractic, physiotherapy, massage, acupuncture, yoga, cryotherapy, which is the application of ice to reduce inflammation, hydrotherapy, which is typically hot tub work to improve range of motion. These have all proven to reduce the symptoms and sometimes even the progression of OA, particularly of the spine and hips or the glenohumeral joints. Devices can help too, such as foot orthotics, which are inserts into shoes, orthopedic pillows to promote better biomechanics within the neck, also different orthopedic seats for the cars, and also braces, say for the knees, can help relieve or prevent OA symptoms. There's a number of herbal remedies that we'll get into in greater detail in the next few slides, because some herbs are naturally anti-inflammatory or analgesic in their properties. And a variety of other natural compounds can help, particularly vitamin C, omega-3 fatty acids, methylsulfonylmethane, also known as MSM, glucosamine, chondroitin sulfate. And we'll get into these in more detail also. Chiropractic manipulations, also called adjustments, of the spine and peripheral joints involves moving the joints slightly beyond their normal range of motion in order to release the joint or realign it, unjam it, or reset it. Joint adjustments are high velocity but low impact and do not damage the joints if the motions are in the appropriate plane. For example, cracking your knuckles does not necessarily damage the joint and increase the risk of OA if it's done in the appropriate way. Hyperflexion or hyperextension or twisting of the knuckle joints does damage the joints, at least slightly, and can increase the risk of OA. However, pulling on those finger joints in a gentle fashion to release the joint does not injure the joint, and it is not related to increased risk of OA. So it depends on how the joints are adjusted, not if or how often. Adjustments create more space in the joint capsule, at least over the short term. They also increase range of motion, decrease pain, reduce surrounding muscle and soft tissue tension, and can stimulate blood and nerve flow. Chiropractic adjustments of joints cannot reverse OA or any joint destruction that may be there, but it can slow its progression and possibly prevent it, particularly in relation to trauma, such as motor vehicle accidents. Essentially, joint adjustments improve the biomechanics of the musculoskeletal system, and therefore reducing the excessive wear and tear of joints. Several controlled clinical trials suggest that the ancient Chinese practice of acupuncture, which is the insertion of very fine needles into so-called meridian points of the body, works effectively to treat osteoarthritic pain and possibly inflammation. Due to the decreased pain and inflammation, it may also help improve joint range of motion. Some clinical studies found that people with OA experience better pain relief and improvement in function with acupuncture compared to certain NSAIDs, such as piroxicam. And perhaps the best thing about acupuncture is that it has no significant negative side effects, which of course is not the case with NSAIDs. There are a number of herbs that display anti-inflammatory and/or analgesic properties. For example, turmeric root is a good anti-inflammatory and analgesic. Perhaps surprisingly, it performs just as well as ibuprofen and diclofenac in studies, but without the side effects. Effective extract doses range from about 300 to 600 milligrams 3 times daily for control of OA symptoms. Turmeric root is also a blood thinner, so caution should be used when taken with medications that are blood thinning or anticoagulants. Cat's claw is another good anti-inflammatory, but it's also an antioxidant and immune booster. It's used not only for OA, but also for rheumatoid arthritis. Effective extract doses range from about 30 to 300 milligrams daily. It's also a diuretic and a vasodilator, so caution should be used when taken with antihypertensive meds. Devil's claw is also a good anti-inflammatory and analgesic. Some studies indicate that taking devil's claw for between 8 to 12 weeks reduces joint pain and improves joint function, especially of the spine, hips, and knees. Effective extract doses range from about 100 to 200 milligrams, taken twice daily. It also displays blood thinning and vasodilating properties, so again, combining this with antihypertensive meds or anticoagulants is not a good idea. Ginger root is another common herbal remedy used to control the symptoms of OA, blocks COX-2 production and reduces inflammation, much like the drug Celebrex does. And of course, like Vioxx also, but that drug's been recalled. At least 2,000 milligrams daily in divided doses needs to be taken to be effective for the symptoms of OA. However, ginger root's also a blood thinner, so combining it with these other herbs or anticoagulant medications is not recommended. Willow bark contains salicin, and it was used in the late 1800s to make synthetic acetylsalicylic acid, or ASA, also known as aspirin. Natural salicin is slower acting for pain relief compared to ASA, but it's much safer and its effects last longer. Effective extract doses range from 300 to 500 milligrams taken 3 times daily. Natural salicin and ASA are also blood thinners. Capsaicin is derived from cayenne peppers and usually mixed in and applied topically as a cream. It works by reducing, at least in the short term, substance P, a chemical that contributes to joint inflammation and pain. It also distracts the brain from focusing on pain signals, because when it's applied to the skin, it creates an intense tingling or burning sensation, and that's distracting. According to studies, at least 3 days of topical application is needed at the site of OA to be effective. However, capsaicin cream or ointments does not improve inflammation or function. As briefly touched on earlier in the presentation, there are a number of natural supplements that can help with OA. Of course, one of them is vitamin C. Depending on gender, pregnancy, or whether or not you smoke, the RDA is between 70 to 120 milligrams per day. And many scientists, including the late Linus Pauling, thought that was far too low. Vitamin C deficiency can result in connective tissue, i.e. cartilage, degeneration. High intake of vitamin C has a threefold reduced risk of OA progression. Of course, Linus Pauling recommended a minimum of 3,000 milligrams per day for people, and he took up to 11 or 12 grams per day and lived a very healthy life to the age of, I believe, either 93 or 94 years old. And he did not experience OA or any other kind of arthritis, by the way. Megadoses of vitamin C, megadoses being at least 1,000 milligrams 3 to 5 times daily, is recommended to significantly impact the symptoms of OA and possibly retard or reverse its progression. Omega-3 fatty acids, and these include either ALA, EPA, and or DHA. All these omega-3 fats have strong anti-inflammatory properties. EPA and DHA are found in fish oils, whereas ALA is found in flaxseed, hemp, and walnuts in abundance. In terms of doses, 1,000 milligrams 2 to 3 times daily is needed for noticeable anti-inflammatory effects. MSM, also called methylsulfonylmethane, is a great source of organic sulfur for the production of chondroitin sulfate. On its own, it's a decent anti-inflammatory and even a mild analgesic. In a large clinical study, 3,000 milligrams of MSM 2 times per day improved pain and physical function associated with OA of the knee. Furthermore, MSM is quite affordable, and there's almost no side effects or downside to taking it. Glucosamine is produced by the chondrocytes and needed to make the GAGs for proteoglycan synthesis. In essence, glucosamine promotes viscosity of the synovial fluid. Interestingly, glucosamine production slows down significantly, naturally, around the age of 50. Numerous studies have found glucosamine sulfate to be effective at reducing pain and inflammation, while increasing mobility in mild to moderate cases of OA, especially large weight-bearing joints, such as the hips and the knees. Glucosamine sulfate, which is a very common supplemental form, is often derived from shellfish. And the downside is there can be some allergy concerns with that supplement. However, glucosamine can also be combined with hydrogen chloride, and although it hasn't performed as well in studies, it hasn't been studied as much. But it is made from vegetable sources, so there's essentially no allergy concerns with glucosamine hydrogen chloride. Effective doses in general are 500 milligrams 3 times daily, for a total of 1,500 milligrams. But for most people, it does take at least 2 months and sometimes up to 4 months for results to be noticeable in terms of reduced pain, inflammation, and increased range of motion. Reduced OA symptoms can continue for up to 3 months even after glucosamine supplements are discontinued. Furthermore, glucosamine is quite affordable, and its side effects, aside from possible allergy concerns, are minimal. Chondroitin is a natural ingredient of cartilage that promotes water absorption. And as you can imagine, absorption of water keeps the joint cartilage hydrated and, if you will, spongy, a better shock absorber. Another role of chondroitin may be to deactivate certain enzymes that can erode cartilage, which leads to fissuring and loss of elasticity. The most common supplemental form is called chondroitin sulfate, and studies indicate that it's effective at reducing symptoms of OA, including pain and joint stiffness and reduced rate of erosion. It can be taken alone, but it's usually combined with glucosamine and or MSM in either liquid supplements, powdered, or tablets. Some studies indicate there may be a synergistic effect if chondroitin and glucosamine are combined, but this hasn't been confirmed and more investigations are needed. Typical effective dosage for chondroitin is about 1,200 milligrams daily, divided into 2 or 3 doses ideally, which is a little less than the typical dose of glucosamine, which is at least 1,500 milligrams and sometimes up to 2,000. Chondroitin supplements are commonly made from processing cartilaginous material from domestic animals, such as cattle. There are literally dozens of medications used to control the symptoms of OA, either due to their anti-inflammatory or analgesic properties. So mainly there are the over-the-counter analgesics or painkillers, the prescription analgesics such as the group called NARCOTICS, over-the-counter anti-inflammatories, typically called NSAIDs, prescription NSAIDs such as COX-2 inhibitors, and sometimes steroidal anti-inflammatories are used for OA also. It's important to note that these medications are not curative, and some may even accelerate joint destruction with long-term use, i.e. 2 years or longer. Acetaminophen is a very common over-the-counter analgesic found in Tylenol products, Excedrin, and others, and it's considered a first-line treatment for OA pain, but of course it doesn't reduce swelling or inflammation. Acetaminophen basically works by changing the way the brain senses or perceives pain. It doesn't work at the site of injury or arthritis. And it may also help a little bit by reducing the body's temperature because it's an antipyretic. Acetaminophen is indicated for mild to moderate pain only, and in this regard its effectiveness is similar to NSAIDs. Acetaminophen actually causes far fewer side effects compared to NSAIDs, but long-term use and high doses are associated with liver damage, and the daily limit is 4,000 milligrams. No medication should be taken with alcohol, but acetaminophen in particular is strongly contraindicated. Doses of acetaminophen for OA are typically between 500 to 1,000 milligrams 3 times daily. Acetaminophen is found in many products, perhaps up to 600 or more, because it's commonly found in cold, sinus fever, and cough remedies. Narcotics are available by prescription only and usually reserved for only severe chronic arthritic pain. Of course, they do not have any impact on inflammation. Narcotics include all opiates, opioids, and synthetic derivatives, which are essentially all derived from the poppy plant. Opiates include morphine and codeine. Semi-synthetic opioids include heroin, oxycodone, and hydrocodone, to name a few examples. The fully synthetic opioids include Demerol, methadone, tramadol, and fentanyl. Opioids affect people quite differently, and they have no upper limit for pain relief. But whatever dose is decided upon, it must be increased gradually to allow for tolerance to adverse effects. The main downside to narcotics is that they are strongly addictive and have toxic side effects. In terms of their ability to relieve pain, comparison to oral morphine, NSAIDs like ibuprofen are about 1/200th as strong for pain. Acetaminophen is about 1/25th as strong. Demerol, compared to morphine, is about 1/3 as strong. Oxycodone is actually stronger, about 2 times stronger than morphine. And fentanyl is between 50 to 100 times stronger than morphine for pain relief. The primary OTC NSAIDs are ibuprofen, brand names Advil, Motrin, naproxen, brand name Aleve or Naprosyn, and acetylsalicylic acid or ASA, brand names aspirin, Anacin, among others. NSAIDs relieve both pain and inflammation, and are generally more effective for severe OA, at least compared to acetaminophen, but they lead to much more side effects, particularly stomach irritation, ulceration, and bleeding. In terms of risk, ASA is much riskier than naproxen, which in turn is riskier than ibuprofen. And although most NSAIDs actually increase the risk of heart attack, naproxen does not. ASA is a non-selective cyclooxygenase or COX inhibitor, but it inhibits more COX-1 enzyme. In contrast, ibuprofen and naproxen are also non-selective COX inhibitors, but they select more of the COX-2 enzymes. The dosages for ASA, at least for OA symptoms, is about 1,000 milligrams 3 times daily. Ibuprofen is between 400 to 800 milligrams every 6 hours to a maximum of 3,200 milligrams. And naproxen is usually a little less, between 250 to 550 milligrams 2 times daily, and its daily maximum is essentially half that of ibuprofen at about 1600 milligrams. Some studies show that long-term use of NSAIDs, i.e. longer than 2 years, actually accelerate cartilage erosion, connective tissue breakdown, and joint destruction. Other common NSAIDs include capsaicin cream or gels, brand name Theragen, and salicylate creams such as the brand name Bengay, and these creams are also available without prescription. COX-2 inhibitors, such as the brand name drug Celebrex, selectively inhibit only COX-2 enzymes, which makes them much easier on the stomach and explains why ibuprofen and naproxen cause fewer stomach ailments compared to ASA. However, COX-2 inhibitors have higher risks of myocardial infarction and stroke compared to other NSAIDs, which in fact prompted the FDA to remove 2 from the US market, which was a pretty drastic move. Vioxx was removed in 2004 and Bextra in 2005. But currently, Celebrex is still on the market. COX-2 inhibitors are also much more expensive compared to other prescription NSAIDs, such as diclofenac, diflucinal, and indomethacin. Celebrex should be prescribed at the lowest possible dose for the shortest time due to its side effects and increased risk of heart attack. Doses are typically 100 milligrams 2 times daily, or sometimes 200 milligrams all at once. Daily dose should not exceed 400 milligrams at the extreme end of things. Here we have a graphic to the right, Celebrex at a glance. It was approved by the FDA in 1998. According to Pfizer, its maker, it is the world's most prescribed arthritis drug. It has been prescribed to 27 million Americans. And also of note, at least 3 times since the Vioxx scandal of 2004, Pfizer has issued press releases affirming the safety of Celebrex. So although Vioxx and Celebrex work in extremely similar manners, Pfizer has done a very good job of distinguishing and separating Celebrex from Vioxx. Corticosteroids such as cortisone and prednisone are strong anti-inflammatories that mimic the natural effects of adrenal hormones. Corticosteroids suppress immunity, which certainly is helpful for autoimmune conditions such as rheumatoid arthritis, lupus, and others, but reducing immunity is not good for health in general. Cortisone is commonly used to inject into large joints, such as the knee and shoulder, and it reduces inflammation and pain quite well. But it's also available as pills, topical creams, and intranasal sprays. Cortisone injections are usually limited to between 2 to 4 per year, especially per joint, but that depends on many factors, including which joint, the effectiveness, and the negative side effects or symptoms. The most common negative side effects from corticosteroid use includes fluid retention or edema, particularly of the limbs, hands, feet, and also the face area. Weight gain, not only from the edema and the fluid retention, but also from excessive fatty deposits. Increased blood pressure and eye pressure, such as glaucoma, due to the fluid retention and edema. Mood swings and fatigue are also quite common with corticosteroid use. And because of the suppression of immunity, slow healing and increased risk of infections are quite a serious concern. Other side effects include thinning of the skin, easy bruising, and also osteoporosis, which is more of a factor with long-term use. Lubrication injections with hyaluronic acid derivatives, the brand names Hyalgan or Synvisc, improve the viscosity of synovial joint fluid, at least in the short term. And with greater viscosity, usually comes less friction, less pain, and possibly better mobility. These injections do not deter or reduce inflammation within the joint. And ironically, joint swelling, due to the relatively minor damage caused by injecting into the joint capsule, is the most common side effect. These injections can also be called viscosupplementation. The injections are usually given into the knee and sometimes the ankle, but usually not other joints such as the spine or the hip. Lubrication injections are very common within the horse racing and jumping industries for horses. They're not as common in people, but that may change as the cost of these injections has been coming down. If the disability, either due to the pain or joint destruction from OA, is significant and conservative management via medications or natural remedies is ineffective, there are various surgeries available for the weight-bearing joints. Arthroscopic surgery for OA, which involves inserting a small scope-like device into the joint capsules, used to trim damaged cartilage and clean out the joint space, are actually not especially effective for OA symptoms. Arthroscopic surgery is very effective at fixing athletic injuries, but not for reducing the progression of OA or significantly reducing the pain and inflammation felt with it. Quite a bit of evidence supports joint replacement therapy or arthroplasty, especially for the knees and hips. These replacements can often significantly reduce pain and increase function. Osteotomy, which is a realigning of bones, is another option, especially for knee osteoarthritis, but it depends on the cause of it. Osteotomy can involve quite a bit of cutting away of bone, so it's much more of an impactful surgery compared to arthroscopic procedures. Arthrodesis is a surgical fusion of joints, usually in the spine, but sometimes of other joints such as the fingers. And arthrodesis is essentially just completing what the body's naturally trying to do on its own, which is joint fusion.